to check my patient order sheet, gather all my equipment, wash my hands, and then introduce myself. So, may I come in?
Yes.
As I come in, I'm going to go ahead and provide for privacy. Hi, my name's Haley. I'm going to be your student nurse today until about 4 o'clock. Can you tell me your name and date of birth, please?
My name is Stephanie Robinette, 41665.
Awesome, Stephanie. Is it okay if I call you Stephanie, or would you prefer me to use a different name?
Stephanie's fine.
Okay, Stephanie. So we're going to be doing a few assessments today. Shouldn't take all that long, but there are going to be 4. Okay. So then I'm going to raise the patient's bed. So our first assessment is respiratory, so that deals with the lungs. So the right lung is actually shorter than the left lung because of the liver. The right lung has 3 lobes. The upper lobe ends at the horizontal fissure in 5th rib. The middle lobe is bordered by the horizontal fissure, the right oblique fissure, and then it ends at the 6th rib. And then the lower lobe begins at the oblique fissure. The left lung is more narrow than the right due to the fact that the heart bulges out more towards the left. The left upper lobe ends at the left oblique fissure in 6th rib, and then the lower lobe begins at these same points. And then on the posterior side, it's important to note that only the upper and lower lobes of both lungs are visible. So both upper lobes end at the T3 vertebrae, and then both lower lobes end at the T10 vertebrae during expiration and T12 vertebrae at inhalation. So then I would check to see if the patient is undergoing any respiratory distress. I would look at if there's any nasal flaring, which it doesn't appear as if there is. And then I would look at the posterior thorax, specifically the AP diameter, so the patient is 2 to 1. And then I would assess the spine. Spine appears straight in midline, and it doesn't visibly appear as if there's any deformities at this moment in time. I would then look at the anterior thorax to see if the patient is using any accessory muscles such as the sternocleidomastoid to aid in breathing, which you are not. Next, I would go on to palpation to see if there are any lumps, masses, or tenderness in the anterior or posterior thorax. So let me know if you experience any tenderness, okay?
Okay.
Any tenderness anywhere?
No.
Back. Any tenderness?
No.
Okay. So then we would move on to chest expansion. So I'm going to come down here at the T9 and T10 space. I'm going to pinch up a little bit of skin so that there's a fold, and then can you please breathe in and out? Okay, so chest expansion is smooth and symmetrical. Go to the front. Make sure that my thumbs are up towards the xiphoid process. Do the same thing. Breathe in and out. Again, chest expansion is smooth and symmetrical. Then I would go on and assess the tactile primitus. So on the front side, there are 4 spots, and then on the back, there are 5 spots that need to be assessed. I'm probably only going to do 2 on the anterior side just because I'm checking for vibrations, and over breast tissue, the vibrations are dulled. So just please say blue moon.
Blue moon.
Again.
Blue moon.
And then I'm actually going to do 1 more.
Blue moon.
Okay, so vibrations are equal on both sides. Go to posterior. Again, say blue moon for me.
Blue moon. Blue moon.
Again.
Blue moon.
Again.
Blue moon.
Again.
Blue moon.
Okay, vibrations were equal on both sides. So then I would go on to percussion. So in percussion, there are 9 points that I need to do on the back. On the shoulder area, there are 3 points that you could choose from, but I'm just going to do the first one. So I go, we're assessing for any resonance. Then we go, seeing if they're equal on both sides. So I am seeing or hearing a hollow sound. So that's 3. You ended up going down to the 7th point, and then 8 and 9 are on the sides. I would check on the anterior, so again, there are 5 spots. in, checking to see if I hear any resonance. And again, I did 3. There are 5 spots. I wouldn't do it over breast tissue just because, again, the sound would be dulled. Then I would auscultate. I would use that, or I would do auscultation using the diaphragm of my bell. I would be listening for pitch, amplitude, duration, quality, and location of sound. So normal breath sounds are bronchial, which are hollow tubular sounds that are more high-pitched. Vestibular, which are slow, soft-pitched sounds that sound more like rustling leaves, and then bronchovestibular, which are mixed quality but moderately pitched. So for auscultation, you would use the same points that you use for percussion. So 5 on the front, 9 on the back. I am going to have you breathe in and out a few times, okay? If you need to take a break, just let me know. Mostly vestibular sounds. Like I said, there are 5. I'm only going to go do 2 just for the purposes of this video. Then I would check the back, again using the 9 spots for auscultation, or auscultation and percussion. So I would start here, breathe, 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 and one more time. Again, I'm hearing mostly vestibular sounds. As I said, you would go down to the 7th spot, and then 8 and 9 are on the sides. So next would be the cardiac assessment. So the heart, as I said before, is mostly on the left side of the chest cavity. It actually extends from the 2nd to 5th intercostal space from the right border of the sternum to the left midclavicular line. So first we would start off with auscultation. So I would listen for the 5 spots that are necessary for a full cardiac assessment. I would start on the right side, which is aortic, which is on the 2nd intercostal space. Then on the left side is when you start pulmonic on the 2nd intercostal space. Go down to 3rd, which is Erb's point, 4th, which is tricuspid, and then 5th, which is mitral. Then I would talk about the physiology of the heart sounds. So the first heart sound that you hear is S1, and this is the beginning of systole. This is when you actually hear a lub sound during the closure of the AV valves, which are the mitral valve and the tricuspid valve. And then the second heart sound that you hear is the S2, and this is the ending of systole. This is when you hear the dub sound during the closure of the SL valves, which are the aortic and pulmonic valves. So the next, I would assess for pulses, or palpate for pulses. So you can do this on the temporal, the carotid, the apical, brachial, radial ulnar, femoral, popliteal, posterior tibial, or pedal. So for the purposes of this video, I'm only going to choose 2, so I'm going to do your carotid, okay? And at the same time, I'm assessing for edema as well as temperature. So no signs of edema, pulse appear to be same on both sides, and your temperature is warm. So is it okay if I do your pedal next? Is it okay if I take off your socks? Yes. We can put them back on after. Next. So then I would check your pedal pulse. Again, assessing for edema as well as temperature. Okay, pulses are even on both sides, no presence of edema, and temperature is warm. Next, I would check capillary refill. So I'm gonna press on your toes here. Okay, refill is less than 2 seconds. Can I have your nails, please? In theory, your capillary refill should be less than 2 seconds, but because you have nails, I can't really assess for that. Next, then I would go on to the neurovascular assessment. So your color of your feet and your hands appear to be similar in color to the rest of your body from what I can tell. I already checked your pedal pulse. Do you experience any pain, numbness, or tingling in either your fingers or your toes?
No.
Okay. Can you have your feet hang for a second and then move them side to side? Okay, so you have good movement, so there's no presence of paralysis. So that ends the neurovascular assessment and the 5 Ps. Next, we would go on to an abdominal assessment. So if you could please go over to the bed over there. Just lay down with your head that way. So I'm going to lower the bed to a supine position so that the patient can have their arms down towards their sides. And then I would start looking at the patient's abdomen. So for this, you would look at the shape and symmetry of the patient's abdomen, as well as I would start assessing to see if there are any scars, hernias, lesions, birthmarks, or even venous patterns. I'm not going to have you lift up your shirt for the purposes of this video, but that's what I would be looking for if this was an actual situation. First, I would actually auscultate. So now the reason that you auscultate first rather than percuss or palpate is because if you did those first, you would end up creating false bowel sounds. So I'm actually going to start in the right lower quadrant due to the fact that the ileocecal makes the most noise. So when I'm listening, I'm going to be listening for pitch, frequency, duration, and location of sound. Put these on. So about 5 to 30 bowel sounds per minute is typical. Yeah, bowel sound there. Like I said, we'll be doing this in each quadrant. If I didn't hear a sound, I would have to auscultate for 5 minutes per quadrant for a total of a 20-minute assessment. So listen. Okay. So after I auscultate, I would then percuss. So in this way, I actually like to think of the stomach as a tic-tac-toe board for 9 different quadrants, and I would make sure that I stay away from the umbilicus by at least 2 inches on all sides. When I'm doing this, I am listening to hear if I hear any tympanic sounds, which is more like air sounds, or any type of dull sounds, which could be due to either fluid or food or potentially masses or tumors. So again, you would do that in each of the 4 quadrants. Slight tap here. Hear that, how that one was kind of dull compared to the first? Okay, so that's percussion. For palpation, I would be palpating for any masses, but then also take note of any organs or like their location. So for the right lower quadrant, the cecum and appendix are present. In the right upper quadrant, the liver and the head of the pancreas are present. Left upper quadrant, the stomach and spleen are present. And then in the left lower quadrant, the sigmoid colon and parts of the descending colon are present. Okay, so that would be the end of the abdominal assessment. So then I would raise your bed up to a 35 to 45 degree angle, but then put it down to the lowest and lock position so that you can go ahead and stand up safely. Get up slowly so you don't get too dizzy. Okay, great. So for the next assessment, it is the musculoskeletal assessment. So I'm going to be assessing your gait first. So if you could just walk over in that direction and then walk back towards me just normally. Okay, so arms are swinging at her side, head is looking forward, doesn't appear as if she's limping or shuffling in any way, joints appear to be symmetrical, and extremity length is appropriate for your age. Then I would start to assess for curvature of your spine, but can you please first put your hands on your hips? Okay, so it appears as if your hips are level, so if you could turn this way, please. So first I'm going to look at the curvature of your spine. So while you're standing, I'm going to run 2 fingers down the middle of your spine to see if I can assess for any atypical curvature. I'm also going to do this while you're bending over, so if you can bend over for me, please. Just have your hands hang. Okay. Again, assess for any curvature. It doesn't appear as if there's any atypical curvature at this moment. Then I put my hands here. Just rise up very slowly, okay? Scapula and spine are symmetrical upon rising. No atypical or unusual joint movement and no nodules are present. After this, we would assess for range of motion of the joints as well as for any pain. So you can do this in your neck, shoulders, elbows, hands, wrists, fingers, hips, knees, ankles, foot, toes, or your TMJ. So for this video, we're going to pick 2. So we're going to look at your shoulders, okay? So just follow my movements and we're just going to see what your range of motion is and if you have any pain. So just lift your arms up, flip, up, flip outwards, go back down. Then we're going to do a little circle. Okay, back down. Do you feel any pain? No. Okay, so it seems like you have full range of motion. So then next I'm going to do your knee. So if you could sit back down, please. Okay, so just kick your knee out for me. I heard some cracking. Is there any pain with that?
No.
Okay. Do it on this one. I heard some cracking. Is there any pain with that one either?
No.
Okay, so it appears like you have full range of motion with that as well. So next we would assess your grip strength. So just grab onto my fingers here and close tightly. Okay, so your strength is bilaterally equal. Then we would do your arms. So grab onto my hands. Try to pull your hands towards you. Okay, try to push my hands away. Okay, your strength is equal on both sides. We would then do it on your legs. So try to bring your leg in towards you. Push away. Okay, bring your leg in towards you. Okay, push away. Okay, again, equal on both sides. And then lastly, we would do your foot. So if you could bring your foot up, please. Press the pedal down. Okay, pull upwards towards the pedal. Press the pedal down. Pull back off the pedal. So again, it appears as if you're equal in strength all around. So that actually ends each of our 4 assessments. The bed is already in the lowest and locked position, but at this time, is there anything that you need between now and the next time that I come in about 30 minutes just to check to make sure you're doing okay?
No, okay.
Okay. If you change your mind, just hit the red call light button and I'll be back in here as soon as I can. Okay. After that, I would dispose of any PPE. I would clean the equipment that touched the patient. So in this case, it would be my stethoscope. I would wash my hands and then I would document everything that I just did.